All right, hi everybody. We're just gonna start off by going over everything that's on sort of a basic oral surgery tray here in the oral surgery clinic. So from left to right, we have our 77R, we have our rongeur, it's an end cutting rongeur. We have our curettes, double-ended. We have our number 9 molt periosteal elevator, bone file. We have our mirror, our number 3 blade handle. We have a toothy pickup, AdSense pickup. We have a hemostat, which is a bit bigger than a smaller version, which would be a mosquito, which we don't have. We have a towel clamp. Here we have our bishops. Over here we have our Fraser sucker, and this is number 12. You can also get a number 10. This is our needle driver, which is often found on the other side of the lid. So whenever you're setting up your tray, don't forget to get out your scissors and your needle driver. And then of course we have our local anesthetic syringe, and we've added 15 blade and a couple of local anesthetic tips, as well as our local anesthetic cartridge. Okay, we're just going to go over the suction. So in order to hook it up to the high volume, you need this little adapter. Okay, this little adapter is going to go between your tubing and the high volume. So we'll just take it over here, and you can see it goes right down into the high volume. Easy peasy, see? There you go, fully seated. And then we can seat our suction onto it as well. Same thing, fully seated. And then turn it on. And then we bring it over and hook it up. Often in a real patient, if this was the patient, you could bring it over to the assistant side, and you can use the towel clip to grab a little bit of the towel on either side of the patient. Let's say this was the patient's towel. You want to make sure, obviously, you don't pinch the patient. You just grab a little bit of towel on either side and trap it in that way. That way the suction is less likely to fall onto the ground, but still has the ability to sort of pull in and out based on your needs. Okay, as far as holding the suction, you come underneath the tubing, all right? So you don't hold it on top like that. You come underneath and kind of hold it like a pencil, like so, and that allows you to suction hard tissues without putting your finger over that hole. And if you're on hard tissues, it's better to put your finger over that hole, and it suctions harder, but it can occlude if you hit things like the tongue or the gingiva. So if you're suctioning soft tissues, once again, say back of the throat, you take your finger off, suction. And if you're doing hard tissues, say the flat's been elevated and you're on bone, then you can put your finger over that hole. But say important just to make sure you come underneath and grab it like a pencil, okay? And that's just way more ergonomic. All right, just wanted to point out the stylet. It's on all the trays for a reason. It's to clean out your suction. So often with longer cases, you get little bits of tooth or bone bugging up your suction. So this is meant to fit right in here and plunger those little bits out. So you can take your sucker off the suction. You can go right in the back this way, and it will get them right out the front, so you can remove the little bit, or you can go the other way with it and put them further up the suction, and then you'll hear them going up the suction tube. So this is your best friend. That will keep things nice and clean, so that you can see what you're doing elsewhere in the procedure. All right, so our local anesthetic syringe, just to review how to put it together. Important to decide whether you're using a self-aspirating or a aspirating syringe. The ones with the harpoon, you can see that little triangle right there, are the ones that are aspirating. So you just have to make sure you give it a little bump to seat that harpoon into that rubber stopper, silicone stopper. Okay, as opposed to if it doesn't have the harpoon, then it's self-aspirating. So no sense in giving it a whack, because there's nothing to drive into that rubber stopper. So you're gonna see, we're gonna bring in our cartridge. This, once it's back, goes a little bit further. It's spring loaded. Okay, and you can see it's spring loaded. So you just put your finger there and pull back to allow room for the cartridge. And you can put your cartridge in and then down like that, okay? And then you can put on your actual needle itself. This little bit here does come off, so just make sure that when you're taking this off that this little bit doesn't come with it, okay? So you can put the cartridge in first and then insert this into the local anesthetic cartridge. And see, I'm being careful to put it in straight on so that it goes into the local anesthetic cartridge nice and clean and doesn't make a tear in that silicone diaphragm, which makes it leaky. Okay, so now all our bits are in there. The only thing we need to do is seat our harpoon. So we just give a little whack like that. Pretty firm little whack. You can see how it's still sitting a little bit up. Okay, so the harpoon is in, but not all the way in. So I'm going to give it another little bump, okay? Just a quick little bump like that, and that's a bit better, okay? If you only have the tip of the harpoon in there, when you go to aspirate, so you've injected the patient, you go to aspirate, so you've done all the hard, painful part, you go to aspirate, your harpoon can pop out, and now you're in no man's land because you're not able to aspirate, so you don't know if you're in an artery or not. So you want to make sure that's seated really nice, make sure the whole triangle is in that rubber stopper before you inject the patient. Okay, so we got our number 3 handle and our number 15 blade. So there's different handles. You can use round ones. The number 3 handles are the typical ones that we use are a little flat. And then our 15 blade, you can see on one side it has this little opening to receive the blade. On the other side, it's completely flush. You can't put the blade on that side because there's nowhere to put it. See, it's smooth. On this side, however, it's got that little notch to hook onto the opening of that 15 blade. Okay, and the bevels match up. You can use an instrument like this. More safe is typically a good option. So you get it going like that. That top edge, you get it sliding in. And then I'm just pulling down with the needle driver until it engages. Okay, so now it's good. What you don't want to do is grab it at any point, obviously on the cutting side, okay? You don't want to grab it with your fingers on the cutting side, on the tip, or with your hemostat. You don't want to damage the cutting surface. So that's why I was making a point of grabbing back here, so it was out of the way of everything. And I have the sharp point pointing away from me, so if there was a slippage, it's only going to go away from you. It's not going to injure you. The other thing you don't want to do is take it, if it hasn't fully clicked on, and jam it into the tray. It will click it on, but now the tip is irreversibly damaged, so it's no good. To undo it, at the end of the procedure, to keep everything safe, you just do the opposite. You come down here and unclick the back end until it's not engaged in that bevel anymore, and then you can go back up where you were before. Same thing, pulling away from you. That way if you slip, you're not going to injure yourself. Okay, so let's say you've fractured off a root of an upper 6. A couple options. One, you could just go after the root using the extraction site that you have. If you wanted to develop a flap using your 15 blade, you typically would do either an envelope or a 3-corner flap in this situation. If you're looking to do a 3-corner flap, often it's you'll go one or two teeth in front of the area of interest, and then one in behind with your release. So typically I would incise front to back, so using the tip of your 15, staying right in the sulcus, right in the embrasure space. Same thing right in that sulcus. Cut your papilla right in that sulcus until you get to the area of your release. You could either do a release here or right at the posterior in behind the 7. I would probably do my release and include the papilla, only so that when I go to put it back, I can put a nice stitch in that papilla to put it back. So like I said, front to back incision. And then I'd often do my release, making sure that your release goes past the mucogingival junction into the unattached to really get good reflection of that flap, okay? So incision, front to back, and then often elevate back to front so you get in there and pop these papillas out. pop, 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 and then elevate it to get good access, and with it reflected back, then you can hold it back with your bishops. It gives you better access to that socket of interest. Okay, so going over a few more instruments here, we got our bishops retractor. So the bishops is sort of a funny S-shaped. Typically this is the end that we have in the mouth. It's got that curvature on purpose because that way light kind of comes in and reflects down onto the area that you're working. So it illuminates the area that you're working in addition to retracting. The other end also is a retractor. It's a sort of a C shape, and we'll use it often in things like orthodontic surgery, just to put in the commissure to move the mouth, sort of the commissure of the mouth. You can see over here. So typically I say I'll use the broad end. I'll get the cheek open a little bit with my periosteal and then bring in my bishops like that. And what you want to do is make sure you're not jamming it against the gingiva and the alveolar ridge. You're just retracting like this, okay? That way you can see everything you're doing without jamming it in. It's very common to be focused on your right hand, your dominant hand in the procedure that you're doing, and forget about your left hand and your retractor, and to jam it in, and then you see a big old line, a big old dent in the gingiva, painful for the patient. So once again, the other way of using it is as a C shape to sort of retract the commissure depending on your needs. As far as how you hold it, there's this big broad section here that typically accommodates 3 or 4 fingers, and I usually have my thumb on the back. I come in like that. It makes it nice and stable. Say thumb on the back to be able to see what you're doing. Moving on to the periosteal. So typically for extracting a tooth, I'll use the sharp end or the cutting end. There is another end, the broad end, which is great for dissecting underneath a flap. But you'll often flip it back and forth and use both ends. But for an extraction, say we're working on this 1/6, typically use my sharp end, and I get right in that gingival sulcus and release the junctional epithelium on the buccal, and then move over to the palatal. Same thing, get right in there and release that junctional epithelium. It really doesn't take that long to do, maybe 10 to 20 seconds. If it's a very periodontally compromised tooth, sometimes it takes a little longer, only because the JE is longer and there's more soft tissue to release. All right, moving on to the 77R. So we've done step 1 of extraction, which is releasing the soft tissue. Step 2, elevation, if you can. It's not a cookbook, so look at the adjacent teeth. Make sure there's no crowns, not heavily restored or periodontally compromised. The adjacent tooth has to be of sound integrity to be able to elevate off of. So always make sure you're using your brain before you pick up this bad boy. So 77R, there are many different types of elevators. This is just one of them. It's my tool of choice, but I say you'll graduate and leave and someone will swear by another one. The principle is expanding the alveolus. This is just a means to an end. So you don't have to use 77R, but this is a 77R. You'll notice that it's C-shaped, so on the back it's curved, and on the front it's got 2 edges, an upper and a lower edges. They're actually a little serrated to help grip so it doesn't slip as much. So typically, if this is the tooth, my finger, the C shape, the grippy edge goes against the thing you're trying to elevate, and then the smooth backside goes against the tooth you're trying to leave behind, okay? You can elevate both ways. You can elevate by leaning in with the top edge or the bottom edge. More commonly, we elevate with the top edge, but every situation is unique. The point and the principle is the same, just to get a nice firm fulcrum on the tooth, and then just gently elevate, keeping an eye on the neighbors to make sure it's creating a therapeutic change and not trauma. So in the mouth, say we go up to this 1/6, once you get in there, and I'll go on the back side here. Common error is people come in at a bad angle, and they come in not parallel to the embrasure space, and they're actually jamming against the adjacent tooth. So word to the wise, you want to get that elevator in parallel with that embrasure, which is typically brings the handle more posterior and closer to the commissure than you would think, okay? And work your way in. And what you want to do is have a finger rest right here. So see how the instrument is in my palm? So firmly seated, and I have a finger rest right here. That way, if there ever was a little slip, you would end up not going any further than your finger, okay? So you get right back there, and so you turn sort of into that tooth, looking at that space between the tooth of interest and the tooth that you're looking to leave behind, often only getting about a 1/2 mil to a mil of space, okay? And usually turning that top edge into the tooth of interest as opposed to the bottom edge. We're not trying to get the tooth out using this, we're just trying to expand the bone. Same thing coming around the mesial, rotate it around, get right in there. Notice how I'm coming in parallel to that embrasure, and then elevating into the tooth, looking at that space that I'm creating, okay? And what we don't want to do is just pump, 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 because pumping it is what causes the discomfort, even with appropriate local anesthesia. What we want to do is create that space and then hold. Hold, 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 hold. It's only when the tooth is at maximum elevation that you're expanding. As soon as you come off it, you're not doing any good towards alveolar expansion. So get it in there, hold, 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 maybe 5-10 seconds, and then come off and go to the other side. Hold, 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 and often going sort of back and forth, and then moving on to your forceps. All right, so now step 3. So step 1 was periosteal, step 2 was elevation, step 3, forceps and extraction. So we're gonna go through a bunch of different forceps. This is the 76S, of course. Lots of different forceps to be used. They often have them written right inside the handle, so you can see which forceps it is. Once you get out and graduate and you'll see the catalogs, there's lots of different versions of lots of different forceps. So you want, it's like sneakers, you gotta find a pair that fits, okay? But the principles are all the same. It's got a little curvature to the handle, so that accommodates the pinky. So different ways of holding it whenever we're coming into the mouth. So this is good for most teeth. Certainly I'll use this for premolar to premolar in the maxilla. So you can hold it sort of underhand like this, which requires you to be down in more of a 7, 8, 9 o'clock position relative to the patient. So I'm down sort of here, okay? You can also hold it, instead of underhand like this, you can hold it like this as well, okay? That requires you to be a little more in 9, 10, 11 o'clock position up here. Also quite comfortable, so you gotta see what works for you, okay? As far as actually using the forceps, like most forceps, you typically bring it in to the palatal first and seat it in that gingival sulcus. So you seat it in that gingival sulcus, and then I'll give it a light squeeze and rotate over to the buccal and get my buccal seated. And often for these front teeth, so premolar, premolar, instead of using the bishops, I'll actually use my fingers to retract the lip and also help with the seating of my forceps. So it gives me a real good feedback, real good proprioception, okay? And then I say often I'll use that underhand grip up at the 11 o'clock position, and then start elevating buccal, palatal, depending on the tooth. Most of these teeth are single rooted. Of course, keeping in mind our 2-4 is often double rooted, so it does have 2 separate roots. Then you can only do minimal rotation, so it's mostly the buccal palatal. When you get to say central or lateral, then I typically would initiate with some rotation instead of the buccal palatal. So seating my forceps, same thing, using my fingers to feel what's going on at the root level underneath. Got my underhand grip, and I would rotate. Notice the forceps is coming down parallel with the long axis of the tooth. So what it's not doing is that, or what it's not doing is that, okay? What happens is if you just focused on the tips and don't realize that the upper part of the forceps is actually going across the neighboring tooth that we're trying to preserve, then as you're going buccal with it, then the actual forceps can engage the neighboring tooth accidentally and damage it. So you want to make sure these beaks are coming down with a long axis of the tooth of interest. and giving a nice squeeze so that whenever you rotate, the tooth rotates. If it's slipping, then you want to think about cleaning off your beaks, trying again, getting a better seat, or switching to a different forceps. What you want to make sure is that your power is translating into the tooth sort of at a one-to-one as best as possible. What we call a 99 forceps. Once again, there's lots of variants out there. I think this one is technically labeled 81, but the principle once again is the same. So this is good for canines, or say you're working on another single rooted tooth and your beaks seem to be slipping a little bit. But typically the only time I use this is if I'm trying a 76 on a canine and it's slipping, and I'll switch to the 99. Principle's the same. You want to get that palatal down, gentle squeeze, rotate over to the buccal, and then get your fingers on there to help retract the soft tissues. And then seat it apically as far as possible. You want those beaks up to at least the CEJ as far as possible, so you're not relying on the integrity of the crown. Your beaks are actually engaged on the root. Often the tooth's coming out because there's something wrong with the crown. It's cracked, fractured, caries, what have you. You want to forget all that, get past the crown, right up past the CEJ, and get onto that root, and then start your rotation movements one way, then the other way. Once again, keeping it nice in line with the long axis of the tooth, not coming in from the side one way or the other. Okay, 18R, so typically what I use for upper molars, just 18R and 18L. And it should be written, once again, right on it somewhere. Don't see it, there we go, 18R. So we know this is for the right, even if it doesn't have that label on it, because of the shape of the beaks. Notice one side has a point on it, and the other one doesn't. So this is for that single palatal root, and this is meant to go in the buccal to accommodate that little furcation between the mesiobuccal and distal buccal roots of a classic upper molar, okay? So as we go in the mouth, it goes in like that for a quad 1, which you'll see. One thing I'd like to point out, one thing I don't like about this forceps is it has what they call an English style handle, where it loops back like that. You can get this exact forceps and both arms are straight like that. I find the way I hold it, it digs into my hand and it hurts. So I don't order ones like this. I order ones with the straight handles. Both of them are straight. So just be aware that you don't have to use ones like this. You can order ones with straight handles, and that goes for other forceps like cow horns as well. So make sure you get the handle you like and the beak. So let's take it in the mouth and see for an upper 6. Once again, you're gonna seat that palatal first, and then light squeeze, and then slide it down mid-buccal so that beaked buccal aspect finds that furcation. And then you can start to rotate it or luxate it buccal and palatal. Back here, I typically don't use my fingers as retractors. I will use the bishops, once again, not hyper-focusing on my forceps, keeping an eye on my bishop so I'm not jamming it into the alveolus. So this is the 18L, so same but different to the 18R, so meant for quad 2, and you can see it's just meant for the opposite side so that the pointed beak is on the buccal and the smooth beak is on the palatal. So once again, bringing it in, seating that palatal beak first, and then rotating over that buccal beak so it slides down in that gingival sulcus, getting in that furcation below the CEJ, giving you a real nice grip on the tooth. So once again, you want to make sure you're parallel with the long axis of the tooth with the beaks. So taking a good look around, making sure that it's not leaned too far back or too far forward, so that when you're luxating the tooth buccal and palatal, your forceps is not accidentally engaging the adjacent tooth. Like this would be an extreme example, but as I'm going buccal, my palatal beak is actually engaging the premolar making it harder to get this tooth out and also damaging the neighboring tooth. So it seems like a practical, silly thing, but in the heat of the moment, pretty easy to get disoriented. So palatal, buccal, keeping those beaks straight up and down so that when you're generating that force, it's only going into the tooth of interest and not damaging the neighbor. Okay, so we got the cow horn. Different numbers for that. Over at the hospital, we call it the 23. Yeah, this one's labeled 23 as well. And sometimes when a patient's anxious and not sedated, I will say 23 instead of cow horn, because cow horn sounds a bit barbaric, but you can see why it gets that name, cow horns. It looks like a couple of moo-moo horns. Fantastic forceps for lower molars that have a nice furcation, especially when the crown's compromised, whether it has a crown undermined with caries or just gross caries. And you can see in the x-ray there's a decent furcation. This can get below all that gnar and get down into that furcation, nice healthy cementum, and get in that furcation and really engage those that root system, that lower molar. Very important when using this forceps to be careful when you're coming in. Of course, there's no tongue in this example, but this needs to be a coordinated effort with your assistant, so they would reach in at this exact point in time and swipe the tongue away with the suction. So I'll just bring it up for demonstration purposes. So the assistant with their right hand would go tongue out of the way, allows you to bring it in and seat that lingual forceps, because what you don't want to do is grab a chunk of tongue or grab a chunk of lingual gingiva like that. Giant no-no. So you want a good visibility, seat it on the crown, slide it into that furcation, and then without moving it, come over to the buccal, and you're just gonna check. You're gonna look at both sides, make sure you haven't done anything silly. Good, still in the sulcus there, still in the sulcus on the buccal, and then start to give some gentle little squeezes to it and rock it up and down. And all you're trying to do is wiggle those beaks into that furcation. You're not giving it a giant squeeze. You're not giving it a giant pump, because you'll just fracture the tooth. Often I'll put a finger on top of it to help support it going down into that furcation. I can sometimes do that with the bishop's hand. If I can't, I'll ask the assistant to take my bishops for a moment, and I say I'll push down with my finger to help seat those beaks down there. As they get further into the furcation, you'll often feel the handles close closer together. Rarely the tooth will pop right out. I say rarely. More commonly, the crown will come out with one root and then you have to go after the other root. Often they'll sink down, nothing's happened, and now you just have an amazing grip on that lower molar, and then you just start rolling it lingual, buccal, until the tooth comes out. If you hear a little crack, don't take the forceps off and abandon it. If you hear a little crack, likely you have most of it, likely you have the crown plus a root. Continue with the extraction and rotate to the buccal and get everything out that you can with your assistant, okay? And then often you'll just be left with a single root. So stick with it. Don't just give up and let go and leave all the broken bits in there. 151 forceps. Let's see if it's branded as such. Looks to be. Great lower molar forceps. So often if I'm doing a lower molar, I'll have this and the cow horn out together, and sometimes switch back and forth between the two of them. This is good if the lower molar, say, doesn't have a nice furcation, so isn't necessarily a cow horn candidate, let's say, and you just want to grab sort of crown plus CEJ instead of using the cow horn. Once again, sometimes I will go back and forth. I'll use the cow horn to loosen up a tooth and maybe finish it off with the 151, but you can be creative. The point is, this is good for lower molars. I like it because it's ergonomic, the way it's shaped. The beaks are in line with the handles, so you can go into the mouth straight on and come down at the molar of interest. Just like the uppers, you want your lingual beak to be in that gingival sulcus, and you get your assistant to swipe the tongue away, and then bring over the buccal. Same thing, mid buccal, no different than the cow horn, but different than the cow horn, you're not going to be pumping it trying to get it down to that furcation. You're going to stand it up. Once again, make sure you are only expanding the alveolus around that single tooth. You're not leaning it far forward like that. Okay, very easy to do in a dark, bloody mouth. You want to stand those beaks straight up and down like that over the tooth of interest, okay? Two ways of doing this. You can grab it underhanded like I'm doing here now and roll it buccal and roll it lingual, or you can do it overhanded like this. Depends what's better for you. My preference is underhanded. I find it more ergonomic. It gets my elbow in closer to my thorax and I'm reaching less and I have more control. Once again, neither one is more right or wrong. Each their own, two ways to get it right. Principles are the same. Meat posterior, personal bias, I don't like it. It's for posterior molars. You can see it's got pointy beaks on the buccal and the lingual to go in the furcation of a posterior molar. The reason I don't like it is because those beaks are going the opposite direction to the handle. Unlike the 151 that you can bring into the mouth and grab onto the tooth, this, in order to grab a hold of the tooth, you have to really move the commissure well out of the way in order to get it lined up with the molar. All right, but same principle, seat the lingual, seat the buccal, and then do some nice controlled buccal lingual forces. I say I rarely use this one only because of the angle that you have to come in to the tooth. I prefer the 151 over that. One good thing to point out though is that when I'm using these forceps, there's no springs on them. So I often grab them and I put my middle anterior, just like the 76S in the maxilla. This is sort of like the 76S in the mandible. Mead anterior, so I'll use this from premolar to premolar. So the premolars, the canine, and the lower incisors. Like I said, lots of variations on these forceps. You can get ones with skinnier beaks, so it's good to have a variety in your practice for, say, a skinny little lower incisor. This might be too wide, but this could be perfect for a premolar. So you want a variety of these forceps depending on which tooth you're taking out. You can see the tips are gripped a little bit. So we'll bring these in, usually standing sort of, once again, over at that sort of 7 to 9 o'clock position. And like most of the forceps, you're gonna seat that lingual aspect. Let's go over to this canine and then the buccal. Want to make sure you're standing straight up and down with the long axis of the tooth. And for the single rooted tooth, just go right into some nice rotational movements. Like that. Okay, once again, I see you can use that for premolar, canine, which I just showed, or lower incisor. Same forceps, very useful. Can't live without it. So here we have the root pick tips and then apexos. So if you're going after a small root tip, you usually use a root pick tip. Lots of different shapes, sizes, angles of root pick tips. So it's not like you have one or you don't. Sometimes I'll call for a long straight like this, or other times I'll ask for, we have small sort of S-shaped little squiggly ones depending on the access and the space that you have. In general, you want something very fine to get right down in that space, that PDL space between your root tip and the socket. If you use something too big, it's just going to push that root tip further up in, all right? Here you can see we have left, right, and straight. Rarely do I use a straight, personally. Usually I'm using left and right. So say this is the hole that you're going in. This is obviously magnified, and I can tell that there's a little space on this side of the root tip. Then I would use this root pick tip and try and get below the leading edge and engage it and flick it up. Say the little space I wanted to get was on that side. You might use that other root pick tip and slide it down there, and you'll often flip back and forth between the two. Rarely using the straight. These apexos often aren't very helpful for small root tips because they are so big. So typically what I use them for is for high upper wisdom teeth to get in behind and parallel to it, and then pop the wisdom tooth out to the buccal. So rarely do I use these for root tips, but just nice to see them together because it can be easy to to confuse. Okay, here we have the criers. Criers, very interesting triangular shape, very aggressive instrument. Typically used for taking out, say you take out a lower molar and you get one root and the other one remains. So let's say this is the extraction socket, and you've removed this root is gone and this root remains. So there's pulp canal system still in there, and then this is all darkness where the root has been removed from. So in this scenario, you're going to want to use this crier because you're going to come into that space that you created by getting one of the roots out and engage the root that remains. Often there's a little bit of bone that's still there, fricational bone. Okay, so there's often a little bit of bone still there, so it's a two-stage movement. You come in, you engage that bone and you get rid of the bone, then you go right back in and you engage that root and elevate it out. It often is a little more traumatic because it does require removal of that frication bone, and it often levers on the patient's mandible and they don't like it. That's often symptomatic up with the TMJ, and for that reason I use them less and less. Having said that, every now and then it's the perfect solution to the situation, so need to know what they are and how to use them. As you can see, there's one that points the other way, so say it was the distal root, you could go in with the other one and do that exact same maneuver. The heel of it does have to rest on something, so usually it's the edge of the socket. This is obviously magnified. So for instructional purposes, we'll look at an upper, but I say rarely would I use it in the upper. It's mostly for lowers. And you want to come in, say there's still a root there. You come in at typically like 45 degrees. If you come in straight down and you try and get that root out, it's too much. You're elevating against the entire jaw. If you come in at too shallow of an angle, it just it pinks off. So it's usually about 45 degrees in order to get low enough down on the root and still be going at a vector capable of extracting that root tip. So good tool in the toolbox, criers. Okay, so bone file. So say we've done a full mouth clearance or really done anything that's involved a flap, and there's some pointy edges that need to be reduced. Bone file is good for smoothing things off. There's two ends, a big end and a small end. Both of the file ends are directional, so they only work when you're pulling towards yourself. They don't work when you're pushing away. Sometimes people will use it in a push-pull fashion, which is okay, but so long as you know that it's only doing something as you're pulling towards yourself when you're doing your alveoloplasty. The rongeur, so this is an end cutting one because it cuts on both the side as well as the end. So you could cut something like this, or you can reach in and nip at it and cut it with just the tips. So very useful for alveoloplasty. If you just use the file, it might take forever. So you often get the big chunks off with a rongeur, or burr it down with something like a number 8 round burr and then finish it off with a bone file. But the rongeur, very useful for shaping things up and initiating that smoothing process. Curettes, super helpful for debriding granulation tissue out of the apex of extraction sites. Also used for all other sorts of things, like sinus lifts, cystonucleation, etc. So you want to pick one that matches the size of your socket. So let's just take the big guy here for our purposes and go in. For getting granulation tissue, often you'll go right into the roots and just kind of go against the socket end and gently curette. What you don't want to do is create complications with your curette. You don't want to be so aggressive that you're busting into the sinus or in the mandible, crushing the inferior alveolar nerve and creating a problem. So I rarely debride routinely. I only debride if there's something there to be debrided, so a cyst or notable granulation tissue at the apex. I don't just do it because I've taken out a tooth, knowing that there's often just a thin shell of bone remaining between you and a sinus or you and a nerve, and there's no need to do it. So I only do it when needed. If there is a little radicular cyst, you don't always scoop at it this way. Often you'll put the tip against the bone and slide it down, and you let the back of the curette do the dissecting for you. So you slide, 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 and same thing like this. Slide, 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 and then at the end you'll give it one nice little scoop to remove the soft tissue of interest. All right, so suture. So often our mainstay here in oral surgery will be the 3O plain gut, FS1. Of course, things can get as complicated as you want, but this, for demonstration purposes, will be the one that we'll use. So often you'll open things up, but in any event, that'll give you access to your stitch. For your needle driver, you want to grab it with your thumb and your ring finger, and just the tips of your finger, okay? See how it can lock on itself? 1, 2, 3. There's no need to lock it all the way tight at any point in time. Usually 1 or 2 is plenty, okay? And once again, just the tips of your finger, thumb, ring finger, and not hubbed in all the way. People get nervous and they get really locked into their needle driver, and you just lose your ability to do some dynamic movements. So just keep it to the fingertips, okay? And then we'll get our stitch out of here, and we'll just pull it free. So here you can see our suture has a flat portion, and at the end it turns around, and that's where it crimps onto the actual suture material itself. So typically you want to grab onto the flat part. If you grab onto the circular part, it will rotate on you. So you choke down and grab onto the flat part, and often you'll grab the suture not at 90 degrees like that. You'll rotate it out so it's maybe like 100 or 110 degrees. It's just more user-friendly to get into the mouth when it's on an angle like that, and just on the tip. So we're going into the mouth. Say we're looking to suture quad 1. So you can use your fingertips, and often going from unattached to attached. So if you've raised the buccal flap, you're going to grab the flappy bit first and stitch it to the solid fixed palatal portion. So you want to get a nice 3mm bite. You don't want to grab the edge like that. That's just going to tear through. You want to grab typically the base of a fila, like this, and I'm going to stitch this. And often going from buccal to palatal, because often our flaps are on the buccal aspect. The principle is you want to go from the moving bit, the flappy bit, to the solid fixed bit, which is often the palatal. So from buccal to palatal. So we'll pull it through. We pull our first bite through, so there's just enough left to tail to the tie, which springs the tail out so it's easy to get to. If you have too long a tail, it's halfway down the patient's cheek and awkward and tough to get to. If you can do both bites in one pass, that's great. If not, just do them separate bites. So same thing, I want a nice, healthy palatal bite that I can hang my hat on. I'm not gonna fall out on the way out to the parking lot. And when I'm grabbing this stitch, I'm not grabbing the tip because that will dull in it. I'm grabbing partway down and rolling it through the same arc of rotation as the shape of the needle, so it's not tearing the gingiva. Pull it tight, and then I'm going to do 2 passes, 1 pass, 1 pass. So 2, 1, 1. So we'll gather the suture up. My ring finger, my thumb. Gather, 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 gather. Put the needle driver over the wound. 1, 2. Grab my tail by the tip, not halfway down, by the tip, and then the tail goes the opposite direction. And at this point, it's critical. It's not locked in there yet, okay? So if I jiggle it, it will all come loose. So I gotta be really careful not to jiggle this until I get my next pass. And see how I jiggled it a bit and it got loose because of the mannequin. And then one more pass the other way. Good. And you want to cut them about 5mm. All right, guys, here we have a side action mouth prop. I use it for almost every extraction because it helps to stabilize the lower jaw whenever you're wiggling out a lower tooth, decreasing the force going up into the TMJs. And certainly for upper teeth, it allows you to titrate how much the patient can open. It allows them to just rest their jaw on the side action instead of having to actively open throughout the procedure. When they go off for sterilization, they often don't have these silicone tubing on where the teeth goes, so you have to keep in stock big rolls of silicone tubing to put new tubing on each and every time you use it. And you can see on the side here, it's sort of the scissor style where you close it and it opens. Okay, so that opens the jaw. In order to release it, you push on the trigger, which allows it to close back down. So it's good to play with it and get used to using it. In the actual patient's mouth, I'll show you how we use it on Mo over here. So I always bring it all into the mouth from the side, and say I'm working on the left side, I put it on the right. And I always ask the patient to open as I'm opening. That way you don't surprise them and crank the jaw open, traumatizing the TMJ. So I stick it in there, back in the sort of the canine area. That way you're not torquing on the small single-rooted teeth anteriorly. And I say open up big as you can. And then you can just rest your jaw on it, and you can see them relax their muscles, and it allows you to get in there and work with the mandible in a controlled position, so it's not changing its position, whether you're working on the tooth, drilling, what have you. The other thing it's good for is doing your block anesthesia. It keeps that ramus in a nice, consistent, predictable location so that you're not going after a moving target. Finger in between so that I can control how much I'm opening it, and then use all the other fingers for closing. Another word to the wise is you want to make sure, say you're working on this 6, not to come in really vertical like that, and then you're working at the end of the tunnel. You want to come right in like that, perpendicular to the tooth, and gives you a much better field of view for what you're doing. If you find it tight on the cheek, you can get the patient to close up a little bit, and that gives you a little more slack if you're working on an upper tooth. Notice the forceps is coming down parallel with the long axis of the tooth. So what it's not doing is that, or what it's not doing is that, okay? What happens is if you just focus on the tips and don't realize that the upper part of the forceps is actually going across the neighboring tooth that we're trying to preserve, then as you're going buccal with it, then the actual forceps can engage the neighboring tooth accidentally and damage it. So you want to make sure these beaks are coming down with a long axis of the tooth of interest. And you can see there's a little tab that comes with it. That's just a lining. You can leave that behind if you do a biopsy. It's kind of useful to use that piece of paper to put your soft tissue on. But here you can see in quad 1, we have it front loaded. Once again, grabbing on that flat portion of our needle so that we can go buccal to palatal in an ergonomic fashion, like so, doop doop. But if we went over to quad 2, for instance, it'd be really awkward, so we actually backload it. So without even unclicking, you can just take the load off by unclicking it but not letting go and rotating it around. So it's going the opposite direction. And now you can get over to quad 2 and same thing, go buccal to palatal in an ergonomic fashion.
Okay guys, little demonstration of a 3/7 surgical extraction using a 3-corner flap. Get in there with your number 9 periosteal elevator, 77R, lone standing tooth, not much to elevate on. Still trying to keep it a closed extraction technique using my cow horn, seating the lingual beak, trying to get into that furcation, followed by the buccal beak. Just wasn't getting in there due to the extensive caries, and I could appreciate that. So instead of trying to stick with it, we move on to a surgical extraction, which is a more appropriate plan, more predictable. Here we see our distal release going distal buccal over that buccal shelf, sulcular incision right in that sulcus. Notice how we start at the back, and then we work our way anteriorly. Here we do a little crestal incision, then I extend my crestal incision a little bit, right up to the distal of that 5, just to give myself a nice broad flap. Then using the pointy end of the periosteal elevator, we develop that flap, typically front to back. Once we're in that subperiosteal plane, it develops quite nicely, and we can get our bishop's retractor in there. At this point, we take our 8 round and develop a nice buccal trough which will allow us to destabilize the tooth. You see, the only thing holding it in is bone, PDL. So take some bone away. Lots of bone to give on this buccal shelf. And it allows us to get a good look at the anatomy of the roots, the furcation. You can just do a buccolingual segmentalization like in the cartoon, but it's a long way to go all the way through the crown and then down through the furcation. So often more and more, I'll just take my 701 burr and just quickly lop the crown off, and that gives you access to the roots. It makes it a lot easier, I find. So I'll do the same thing on maxillary molars, just lop the crown off at the CEJ. Basically get most of the way through. And then that last little bit, you use your 77R. Notice I'm putting gauze in there just to make sure the patient doesn't aspirate the tooth. And either put a finger or the suction on a cusp of the tooth so it doesn't go flying. Crack the crown off, remove it with a mosquito, and now you're just left with the root system. So a much more predictable situation. You really appreciate we're right in the pulp chamber there, so we're just using the 701 to cleanly segmentalize in a buccolingual fashion. I say you could do this with the crown on. It's just harder to see that furcation coming down with the crown on compared to with the crown essentially out of the way. And then running that 701 burr around both the mesial and the distal roots, really making sure, see them the whole depth of the 701 burr. And then I'll get in there with the 77R to make sure that they're moving independent of one another. But really take my time, make a nice clean slot. Making sure we got two separate roots here, so we're going to treat them as two separate teeth. Just showing off my handiwork here, knowing that this lecture was coming down the pipe in a asynchronous fashion. We're really trying to optimize some of these things like this video, which we didn't have in the past. So great option. Letting the roots talk to me. Mesial one says he wants to come, so out it comes. 77R using that slot I made. So this is a tooth that went from not wanting to come out with a forceps to coming out pretty easy when we go surgical. So mesial root out. Just a root, a little more stuck in there. If it popped right out with 77R, we'd be done now. Just didn't really want to. Comes here to work out a little harder on the distal. And then finish it off with the mosquito. Very important after a surgical extraction to wash it all out. Big wash. Under that flap, we want to get down in the socket, but also where that subperiosteal plane to get all the bone dust out of there, minimize the likelihood of infection. Putting our flap back, 3-corner flap, so we're doing that corner, the distal corner first of our 3-corner flap, right where it used to meet the distal buccal line angle of that 3-7. So tacking that back, that way we know that the flap is back in its proper orientation, front back. Most important suture of the flap is this one right here. That will resuspend the whole thing and make sure that we're not stealing tissue away anteriorly or posteriorly. Once the corner's tacked, then we can do our sulcular incision, or in this case our alveolar ridge incision. And then last but not least, we can do our distal release. After you've done the corner, it's not super important which sequence you do them in, but the most important one is getting that corner done first. So lots of interrupted plain gut 3/0 sutures. You can see the whole flap's resuspended, washed out nicely, tooth gone. Everybody's happy.